Hello, everyone. Welcome to the Muse webinar. This is Medical Debt and the Pursuit of Health Equity. I'm Alicia Roberts with Muse. Our presenters are Anita Karts and Ruth Londay. Before we get started, just a few points. You are muted, so you'll need to type your questions into the question box on your GoToWebinar control panel and press send. We will read your questions in the order that we receive them, and we'll take questions throughout the webinar and at the end of the webinar. You can also request to be unmuted by clicking the yellow hand icon located in the top left corner of your GoToWebinar control panel. That will indicate to me that you'd like to be unmuted, and I can do so at the appointed time. We are recording the webinar, and when it completes, we will post it on the Muse website under the Resources tab. We will also post our slides from our session there as well, and you will be able to access those. So now I would like to welcome Anita as our presenter. I'm going to turn things over to her. Anita, thank you so much.
Thank you, Alicia. So, welcome. Thank you all for joining us today. And basically, I'd like to introduce the two of us. I'm going to lead in today, talk a little bit about health equity, and then turn the virtual podium over to Ruth. I am the Chief Medical Officer and co-founder of the Institute for Health Metrics. We're a not-for-profit. We are a Muse commercial member. And what we do is we work with hospitals and their data to help advance health equity. We work with social determinants of health data and are very excited about doing that. And as you know, there's a lot going on in that area. And I will not wax wax more vociferous at this point about that. I will contain myself. But it is a very interesting and exciting topic for so many different reasons. Ruth, would you like to introduce yourself?
Sure, briefly. My name's Ruth Londay, and my role right now is as Vice President of Hospital Relations, basically debt acquisition at RIP Medical Debt. We're a national charity, and before that I worked for hospitals doing revenue cycle work.
Great, thank you, Ruth. So just to talk about a little bit about our agenda for this session. So I'm going to talk a little bit about where we are today around setting the stage for health disparities, health equity, and how medical debt fits within that framework. Then I'm going to turn it over to Ruth, who's going to be talking about medical debt disparities and hospital strategies to work on this. And then we'd like to entertain questions and really turn this into more of a discussion about these items. So to begin with, I'd like to just talk about some of the high-level information that we all have heard of and in the back of our minds carry around. But when we look at it, it's really a very stark reminder of where we are. What do we spend? We spend more in the US, and I know if you look at this graphic, and you'll get a copy of the slides that you can look at, but if you get, you're basically looking at this graphic and you're saying, well, I can't really quite read all the countries here. But it doesn't matter that you can't read the other countries. It's Scandinavia, Canada, Germany, France, etc. But the US, this is the US. We're way up here in what we spend, the red line. And that gap of what we spend is higher and keeps getting higher over time. However, what do we get for it? when you start looking here, how do we compare? We're down here. So clearly, despite all the money we spend in our healthcare system, we underperform compared to these other high-income nations. And why is that? Because we have significant disparities in how people access healthcare, preventative care, and how basic socioeconomic needs are met in the US. And this comes down to social determinants of health and health disparities. And what are social determinants of health? And I'm sure you've heard that term. But really what it comes down to are different things that affect your health status. So for example, your transportation. Can you get there? Can you get to the doctor if you have no transportation? You're socially isolated. You have to take multiple buses, or maybe you can't even get there on public transportation. You can't pay for your medical care. Do you ration your insulin? There are all sorts of questions that target and highlight social determinants of health. Food insecurity, for example, is a classic example of a social determinant of health. Now, why are we thinking about this? Well, if you look at those other countries, they pay much more attention to social determinants of health. So that really affects things like life expectancy, infant mortality rate, the common measures that we look at when we look at population health in a country. And when we look at social determinants of health, we often look at them in these 5 categories. And this is basically from CMS, Healthy People 2030. And what we're going to be talking about here in light of medical debt really has to do with economic stability. And essentially there, the issue is economic. How can you pay your bills, for example? If there's still a lack of universal health care coverage in this country, although this has improved with the ACA, about 10% of the population is still uninsured. And now, with the end of the COVID public health emergency, states are beginning to drop people from mandated Medicaid coverage. So we're going to see less coverage. And there are other things that will affect the economics of coverage, or do affect economics of coverage, that Ruth will talk about as she goes further and talks about the issues surrounding medical debt. So with that lead in, I'm going to turn the virtual podium over to Ruth. Ruth?
All right, thank you. So yeah, so in terms of social determinants of health, there is an emerging literature that, in addition to the items that Anita mentioned, the housing and transportation, lists medical debt itself as a social determinant of health. And here are 2 recent examples from JAMA. The second one there, the one that's prevalence and risk factors, specifically talks not only about how medical debt is common, but that it affects other social determinants. In other words, once you have medical debt, you're more likely to have other issues such as the housing and food insecurity. So they're definitely very intertwined. And in some sense, it's not new. There's certainly been years of literature on the health hazards of being uninsured, right? That's been a thing that's been talked about for some time, as well as literature about the problem of high deductibles. This idea, which really started 2003, federal policy, so this preceded the ACA. Federal policy set in place some things that encouraged high deductibles with the idea that patients would be consumers and they would choose things better. And there's a whole philosophy there, which a lot of research has shown do not work out the way that they are planned. In fact, people simply don't get care, even useful, what we would consider high value care. So yeah, it's there's also studies that just look at, you know, how many Americans defer care because of cost, and those numbers are consistently high. All right, next slide. Another thing that we've seen happening is that it's really, people are starting to talk about healthcare billing in the quality metric space. So Leapfrog most recently, which does quality ratings. And some of you, we've got an eclectic audience here. Some of you are quality people, some of you are finance people. So you'll all be experts in different parts of this. But Leapfrog added billing ethics questions to their quality measures. They just did a first round. They actually reached out to my organization, RIP Medical Debt, to ask a bit about our experience and consult with us as they created those billing ethics questions. So, and certainly I recall when I worked at a hospital that if their prior authorization or other billing hurdles delayed care, that sometimes all the quality folks would come in and do one of those assessments that they do to say, did that in fact make their cancer worse because we had a delay of a couple of weeks, and really taking a look at those kinds of issues. So yeah, these financial issues unfortunately do get entwined with quality issues. And Joint Commission, which assesses hospitals, has also added health equity to their national patient safety goals. So folks are starting to understand this is right in there, that in order to give good care, we need to take a look at what the role is of the billing process. All right, so next slide. So, you know, it is in the media a lot now, but I'll just pause to point out how pervasive medical debt is. So even though 90% of the countries Anita just said have insurance, many more people, whether they're insured or not, have medical debt. This is from a Kaiser Family Foundation study last June, which you can more details about. A lot of very difficult stuff. And the way they defined it is medical debt is any money that you owe, whether it's on a credit card or to your family, you're paying it over time for some either medical or dental care that you got. Now you may ask, gosh, you know, can we be more scientific than doing surveys? And in fact, surveys are really the best way to measure this, because there's really no other one place to find how much medical debt there is. This is one of the things researchers struggle with. There's a really, I'll just mention, there's a really great Urban Institute study, which is you can drill into your state and drill into your county, which is really great because there, of course, are some geographic disparities as well, and you can look at the race implications. However, that draws only on medical debt that shows up on people's credit reports. That was their source. And there's lots of medical debt that never gets reported to the credit agencies. So that really is a subset. So it's a useful subset in terms of researchers, but there's really a lot more. And particularly now as interest rates go up and people are paying more and more on their credit cards, we're really talking about you know, a lot of debt in a lot of places. And the next slide is also draws from that same Kaiser Family Foundation study, just looking at what people are giving up when they're having to pay their bills. They're using up their savings, they're taking extra jobs, all those sorts of things that are affecting people's lives, and obviously not exactly helping their health if they can't sleep because they're taking on night jobs, if they're cutting back, you know, spending on vacations or anything that might give them some psychological relief. All right, so the next slide, so that's sort of the problem, and I guess this almost sort of is a little repetitious perhaps, but I think it's kind of obvious to most people that it's not like going out and buying something frivolous, that medical debt is not a debt of choice. There's a lot of data that most households can't handle a unexpected $500 bill, and reminder that deductibles are often a few thousands. And again, that it is more prevalent, it's linked to all these other SDOHs and the history of our country and how things have been allocated, and it is the leading cause of bankruptcy. So I think on this slide, the one thing I would emphasize, because I have to be admit that as somebody who used to do hospital billing for many decades, I don't think I thought about the impact on a patient that went beyond the time that I stopped trying to collect. So in other words, you're a physician group or a hospital or whatever kind of healthcare provider, and you feel like you're doing a good job. You don't sue people, perhaps you don't do some of those extremes, and you think, okay, well, I send out a bunch of bills, but I guess if they don't pay it, I'm just going to remove it from their receivable and go on my merry way. I haven't done any harm to anybody. But in fact, what we have discovered at RIP Medical Debt is that just by sending bills to people who can't afford them, you do cause the harm and the anxiety. And people remember that even after you stop sending the bills. And so this is what our beneficiaries tell us all the time. You can go to the RIP Medical Debt website and read some of the stories. But people, they still drive by the hospital where they had that incident, right? And they remember that they got those bills and they were so freaked out by them because they were struggling. They didn't even necessarily open them, but they remember, I didn't pay that bill. And that makes them much less likely to go and seek care when they need it, thinking, I don't want to run up even more debt, and they feel shame and guilt about it. So this is why even getting rid of old debt, or letting your patients know if you're no longer billing them or why really makes a difference, because people carry that burden with them. All right, so the next slide, this is sort of the slide that I feel like, so if you are somebody who does billing, you already know this. But for the rest of the world, for what I'll call normal people who are not in this strange space for a living, a lot of people just blame healthcare providers and say, oh, what's wrong with you? You're charging too much, and you're all bad. But in fact, it's a systemic issue, and that really hurts providers too. So I already mentioned that there are systemic federal law which encourages these high deductibles, which people can't afford. Certainly hospitals would prefer to just bill insurers, but again, these deductibles are out there and they're a problem. People, because their insurance is tied to their jobs, and people have these disruptions. Certainly we saw that around COVID. They're just finding out what somebody's insurance is on any given day, particularly over the course of the treatment, say for a chronic illness, it goes up and down. You get authorization for care. When I worked in a cancer center, you get authorization for a whole bunch of chemotherapy treatments from their insurer. 2 months later, they're on a different insurer. You have to go back and redo that again. I mean, that's just, it's a terrible system. It's a lot of overhead. And there are a lot of denials that are seen very Kafkaesque if you're a provider, questioning the medical necessity of all sorts of treatments. As we know, some parts of the country have not expanded Medicaid the way that others have. So there's still a lot of low-income people who are not eligible. And here's one of the things that gets talked about, which is financial assistance. So not-for-profit hospitals provide financial assistance. And there's some folks in the community say, you didn't tell me you had financial assistance. And there's sort of a whole battle around this. The fact is that hospitals do put it on every bill, but who's going to read all of that fine print, especially when we're dealing with something very unaffordable. So there's really a problem where also people are very proud in this country. I don't need assistance. That word assistance, people like, I'm working, I have insurance, I don't need assistance from anybody. So the fact is many eligible patients don't apply. There is, if you're a more wealthy health system, there's new technology which allows health systems to simply find out the income of most of their patients through tools which look for presumptive eligibility, that is finding out the income of people without them filling out a form. However, that costs as well for the hospital. You have to pay transaction costs. So again, hospitals are trying to hire nurses and do all sorts of things. And it's, how often are you going to run those kinds of things? And in general, hospitals do have large revenue cycle departments, that is billing departments, but you're mostly focused on the insurance stuff and the younger stuff. And honestly, some of these patient bills just don't get closely looked at. So next slide. Just because, now again, what I'm saying is, so hospitals are sort of, other providers are put in a hard situation because of the system in this country. However, that does not mean they are helpless. And so this is where I make some recommendations from my experience both in that sector as well as getting to work at RIP Medical Debt. One is you could contact RIP Medical Debt and work with us. That is certainly an option, and you can contact me to find out more. We pay you for your debt. We give you a lot of information, and we help your patients. But even if you don't do that, there are some things that you can do. And I referred already to this communication gap. So given that many people don't read their bills because they're just very frightened by those bills, there are other trusted people who can help get the word out about financial assistance, and particularly clinicians. I'm not talking so much doctors, so yes, doctors, but nurses particularly, who are very close to the patient and trusted generally, seeing the patient over time, social workers, whoever you have, community groups out there in those, whether it's a church community group who they have a trusted relationship with the community, you can say, hey, did you know if you have this income, you can be getting financial assistance. And what you want is for those emissaries, those community groups and those nurses to be able to make a direct referral to your program. So you don't actually have them tell you and then the patient has to do it. Remember, they're low income, they're sick, they've got enough going on in their plates. So have those folks being able to make a direct referral can really be of assistance. And also another thing, one of the hospitals I worked at, right in the clinical intake form, would ask various questions, and that's, I think, getting more and more common to ask SDOH kind of questions. And one of those questions right up front can be, are you concerned about your ability to pay for your bills? So right there, you're grabbing, you can then reach out to the patient and help them. Secondly, I would recommend really looking at the eligibility criteria because, again, it may have been fine a few years ago, but given especially the cost of housing in most communities in this country, the cost of rent, really, it may be that you're really not offering a high enough poverty level, and or you're very focused on the uninsured. And again, once upon a time, maybe just focusing on the uninsured was doing enough of a job for your community. But at this point, the majority of bad debt is for the insured. Also, some folks using asset tests that are really onerous, that are probably taking your staff a lot of time and really not necessarily helping you very much. I made a mention already of the presumptive eligibility software that hospitals can use, which does cost, but is more efficient. So you want to look at when you use that. Can you use it early before you send bills out? Also, this is a little in the weeds, but feel free to contact me later. But there's something called propensity to pay, which is really kind of not a useful tool within those things. You really want to just go for straight income. Propensity to pay essentially means, say you're somebody on a fixed income, you've always paid your bills on time. It says, oh, you have a great propensity to pay. Does not mean you have an ability to pay. So that's that distinction there. Notifying patients. So one of the things, again, it's built into most billing systems. You know, you go, you bill, you offer assistance. It ends up as charity care or becomes bad debt. You don't tend to notify the patient just because the system doesn't. So there's a lot of people that you give presumptive eligibility to. You give the person charity care and you never tell them. So here's a community who's often benefited from your programs, your charity or financial assistance programs, but they don't know. I mean, no wonder they get mad at the hospital. And so if you can find ways to really share that information, I've been pushing Epic, and I know that this is a Meditech user group. So maybe this is where Meditech, if you haven't done it, can get ahead of Epic and really find a way to make sure that patients are aware of what's happened to their balances. And finally, I would simply say, get feedback on your program because you know, it's an area where you don't always know how your community is looking at you. And whether it's through community groups, there's a not-for-profit group called $4. And I have to say, they're a little hard on what they say about hospitals. But, you know, sometimes you got to invite your alleged enemy in the room. Call them and say, could you give me some feedback on how it is when the patients you're helping apply to my hospital versus some other hospitals? Give me some feedback. Can't hurt. It's free. And maybe you'll find out that there's something on your form that's really problematic and you just didn't know. So that's the list of advice for free that I'm giving out today. Let's see. Is that our last slide, Anita? Yes, it is. All right. So good. Now we get to turn into a dialogue, which is much more fun. And yeah, we welcome your questions.
All right, thank you so much. So if you joined us late or perhaps you missed the very beginning of our webinar, we kind of went over how you can send your questions in. So that's the time we have reached now. So you can type your questions into the question box on your GoToWebinar control panel and press send. Or if you would rather vocally ask your question or make your comment, you can click the yellow hand icon in the top left corner and I will unmute you so that you can ask your question. So let's get started here. Our first question. Okay, so we do have the question. I'm going to go over this again too. We talked about it at the beginning, but so Brandy has asked, how can we download the presentation? So what will happen, we are recording today, and the recording and the slides we will post on the Muse website in the resources section, and you'll be able to click the webinar, watch it again, download the slides, anything you would like to do with that. So that is where that's located. Okay, how is RIP-MD different than a debt collector?
Okay. Yeah, we don't do any collections at all, ever, ever, ever. So that's yeah. The only similarity between us and is that we are using the mechanism of debt buying, which there's a whole commercial market for debt. We're using that mechanism and the pricing to buy the debt, but then there's never any collections. All we do is look for low-income patients from your receivable, and we write those balances off. We notify the patient with a letter that says your debt is gone, paid for by people in the community. You don't have to do a thing.
Okay, so that kind of, to me, I feel like that explains a bit of my next question, but so why would a hospital choose to work with you?
Well, yeah, I mean, hospitals have limited resources, as I was describing, and they're generally very committed to the health of their community, and they know there are people out there who have debt, who basically fell through the cracks, and they feel bad about it, and they want to make sure those folks are not delaying care and not getting care because of those past debts. So by working with us, we pay the hospital for their older bad debts, so they get a little bit of money, not much, but you know, I mean, honestly, hospitals are so hard up these days and getting things helpful. And what we do is we send out letters to those patients and say, hey, your debt is gone. So it's just a very easy, no cost kind of way for a hospital to reach out to the community and take care of it's not something the hospital ever, unintended, that's the word I wanted, unintended consequences of past billing practices, and give the community some relief.
So related to this still a little bit, what's all kind of interrelated, but when you are looking through that information, how do you establish a patient's financial hardship?
Yep, that's a good question. So we use TransUnion, but I mean, you know, these are the kinds of tools that, in fact, hospitals sometimes use for presumptive eligibility. We use TransUnion to pull the income of the patients, and we look for anybody who's under 400% of the federal poverty level, and or the debt is more than 5% of their income. So it's only those lower income accounts, which frankly, every hospital we've worked with around the country, it's the majority of their bad debt are lower income people. The people don't pay often, they're not paying because they can't afford to pay. But that's the tool that we use to find the what we call qualifying individuals.
All right, thank you. So who is communicating with the patients? Is it you? Is it the hospital? Who's doing that communication?
Yeah, so RIP Medical Debt is sending out a letter. A hospital can see what the letter looks like, but basically just a letter to say that, you know, RIP Medical Debt acquired your debt, paid for by people in the community, and that this is a gift, and by law there's no tax consequence of the gift, because I'm not a lawyer, we are a disinterested charitable party, but that's the language, and so they don't have to do anything, but they know that that debt has been abolished. And if they would like to share their experience, they can. And that's how you get a lot of those experiences on the RIP Medical website, RIP Medical Debt website. And actually, we have a staff anthropologist who is helping us. She's the one who really talks to people who do share their stories. She's collating them and looking at themes. This is sort of the kind of research, because we know in the end that the work that we do is not the answer. We're cleaning up behind, but it's not the answer. The answer comes at a policy level, right? And there's lots of people pushing for policy changes that will do that. And we want to support that. And so we feel like the stories that our anthropologist is gathering, those stories and the themes in those stories are ones that we can lift up and offer as part of data to support making that change. So that's perhaps a long answer to your question.
No, that's great. No, thank you. So as you're working with these patients and you're eliminating or totally wiping out their debt, how does that relate to Medicare? Are we breaking rules here? What's the story with Medicare?
Yeah, no, it's not breaking any rules. We have a whole bunch of fancy healthcare lawyers on our board. And in fact, before we started getting debt directly from providers, we got an OIG opinion, CMS OIG opinion to say that it's perfectly fine. It doesn't break any rules. Again, you can't, a hospital can't, for folks who are not in compliance, you can't just decide not to bill patients. You have to do it unless there's demonstrated financial need. And obviously for all these folks, there is demonstrated financial need. So it's perfectly fine for hospitals to work with us. And if you really want to get all wonky, I didn't see anybody who was a reimbursement analyst. There's some stuff about how this interfaces with Medicare bad debt payments, where you have to take our payment as a recovery. Anyway, it's not an obstacle. It's it'll work in with all of your other reimbursement, and there are no legal issues at all. You obviously sign a BAA so that sharing of data is safe from a cybersecurity and HIPAA point of view as well.
Okay, so what about hospitals who already have a financial assistance policy? Can you still find that qualified medical debt?
Yes, yes. I mean, every hospital we work with, they've got these policies. They really are good actors. I know so often people think, oh, it's a problem with bad hospitals out there, but not with me. I have to tell you, every hospital we work with, these are good hospitals, and we do have financial assistance policies. The problem is that people are not getting caught. They're not applying. So we do find the majority of the bad debt that we receive qualifies. Usually like 85% of the files, sometimes 90 or more percent of the files. So, yeah, it's unfortunately it's pervasive.
Okay, so I'm going to tag on to that and ask this question. How does this impact, improve, affect the hospital's economics?
Yeah, well, I mean, so I think it's partly what the hospital does with it. I mean, we do pay money, though it's, again, not a huge amount. It's usually like a penny on the dollar that we pay, though people have millions of dollars sometimes in past years bad debt. So you get some payment. But this is essentially, we're taking old bad debt that the hospital is no longer trying to pursue and giving some money for. So that's a positive. But really, moreover, it's giving you data to look at. Here are the people that we're missing. And so then the hospital can look at that. Is it maybe particular locations? Is it patients who live outside of our area? Is it the insured, but we're getting all the uninsured? Is it maybe, hospital systems now are very complex. Sometimes they merge with other hospitals. And so you're kind of dealing with a whole bunch of history there. But you can modify your financial assistance policies and practices and your billing practices in general based on this data. So that could really help you with your future charity care, getting those numbers up and really pushing back against a community narrative that says, oh, hospitals are all evil. We know this isn't true. I think everybody in this webinar and knows that. But there are ways to really push against that. In fact, next month at the annual HFMA meeting, the Healthcare Finance Management Association meeting, we're talking a bit, I'm presenting there with some leadership of the group, how do we start both changing practices and changing how we're sharing those stories? Because essentially, when people don't trust their own healthcare providers, that in itself is not good for your health. If they make a treatment recommendation, you're thinking, oh, they're out to get me money-wise. I mean, we need to, I don't want to go overboard. Anita was talking to herself about trying to hold back. Sometimes I need to hold back too. I feel so passionately about this. But we need to find ways to change this trust relationship. So yes, working with RIP Medical Debt can help give you information, help your charity care, help to really show the community the dedication that you have.
All right, Ruth, thank you so much for that answer. So the next question, switching gears just a little bit here. So is delaying care, is that the only connection between medical debt and health? And if it's not, or if it is, what are some others?
Anita, you want to try that one?
Well, I think it's a reluctance to, it's delaying care, reluctance to seek care at all. I mean, if you need something, I mean, think about screening, cancer screening, right? I mean, you're not going to go and get your screening mammogram or your screening colonoscopy if you already have medical debt and you can't pay for those screening procedures, right? Or you won't do it. And the thing is, you're delaying, you're not delaying, quote, necessary care, you're delaying screening that could be very valuable for your care. So I think there are many different things that medical debt affects in terms of the perception of what care do I seek or ignore.
Mm-hmm. Yeah, or chronic diseases like diabetes. I mean, if you
Right.
don't, you're the physician or not, but people end up with amputations because of untreated diabetes. Yeah.
Yeah, or there's been a lot in the press in the past few months about people rationing insulin because they can't afford it.
Yeah.
And
Yeah.
that's good because it means you're not treating yourself appropriately.
Yeah, I would recommend, Anita used some slides early on from the Commonwealth Fund. They have just some amazing graphics, around this, around these issues, and I think it's exactly those kinds of very treatable illnesses that make such a difference in our life expectancy being so much lower than these other countries, because it's not somebody getting hit by a truck; it's these chronic diseases that are perfectly treatable with current science, which we're not allocating our resources such that people, we're not even giving people sick time at their job so that they can go and rest. But that's, a whole other thing.
Yeah. All right. So moving on here, our next question, and this is switching gears even more. So how did COVID, the whole process of COVID and the end of COVID, how did that affect patient debt?
On the debt side, actually, debt went down a bit nationally during COVID, probably for the first time, and that's partly because there were some more supports. There were a lot of different supports that came through to help people, and people obviously also couldn't spend their money on other things. You couldn't get evicted. There were all sorts of things going on to help people. So the stats show, from the hospital's point of view, that debt went down a little bit. Which is great, but at this point now it's soaring up again, and of course the increase in interest rates also makes it far worse, because a lot of people just try to throw it onto their credit cards, and if their credit cards are having higher interest, there's a lot of debt that ends up there. So yeah, I would say a little bit of a respite and some good policies out there, but at this point that advantage has been lost. Yeah.
All right. Well, I'm going to give one more call. I'm not seeing any other questions in the question box. I don't see any hands raised here, but I will give it just a few more seconds in case someone is typing. I don't want to cut that off. So while I do that, I'll just direct you back to the screen here. So if you have a question that you'd just rather ask directly, or maybe you think of it later, Ruth and Anita have both displayed their email addresses here on the screen. So if you want to take a second and look at those, again, we will post these slides so you have access to this later. But their email addresses are here. If you'd rather reach out individually or directly, you can certainly do that. As I mentioned, we will post this all. I will send you an email with a follow-up, and I'll include the exact directions to download the slides and access the presentation. So I am not seeing any more questions come in. So Anita and Ruth, I'd just like to thank you so much for your time and all your work you put into this presentation. I know this brought so much value for our attendees. Thank you so much. And thank you to all of our attendees for joining in and participating today. And with that, I'd like to turn it to Ruth and Anita. Do you have any closing comments?
No, I mean, I really appreciate being here, Anita reaching out, and because this is actually, it's unusual to bring these groups together, and I think it's really, really necessary if we're ever going to make some change. So really appreciate it.
Agreed. And I've known of RIP Medical Debt for quite a while, and I've always been impressed with what they've been doing, and it's great to share the podium here with Ruth, and look forward to continuing to do some work together. And hope to see everybody at the Muse conference in Denver.
All right, Anita, thank you so much for that plug. Yes, you can still register for the Muse Inspire conference at the Gaylord Rockies, right outside of Denver. You can just go to the Muse website there on the homepage. You'll see the link to register. We are still taking registrations. So if you haven't checked that out, you definitely want to do that. But that will bring us to the close of our webinar. Again, everyone, thank you so much for joining in, and enjoy the rest of your day. Bye, everybody.
Great. Thank you all.
Thank you. Bye.
Bye.